Tetralogy of Fallot. Introduction and background. TOF is characterized by the following four features: a non-restrictive VSD, overriding of aorta but less than 50%, infundibular, valvular, supravalvular RVOT obstruction and or branch pulmonary artery stenosis, and consequent RV hypertrophy. Top populations can be subdivided into syndromic patients 20%, such as microdeletion 22q11, trisomy 21, Alagille, Noonan, Williams, and Klippel-Feil, and non-syndromic patients, which represent the vast majority. The standardized mortality rate among patients with repaired TOF is almost twice as high as among patients with simple defects, ASD and VSD. Now, clinical presentation and natural history. Surgical repair of TOF has evolved over time, with relief of the RVOT obstruction usually involving infundibulotomy, resection of obstructive muscle bands, and the use of a patch to enlarge the pathway from the RV to the pulmonary arteries. In some patients, a palliative shunt procedure in order to increase pulmonary blood flow has been performed before repair. Common complications in adulthood are pulmonary regurgitation. Significant pulmonary regurgitation is almost always encountered following a transannular patch repair. Pulmonary regurgitation is usually well tolerated for years. Severe chronic pulmonary regurgitation, however, eventually leads to symptomatic RV dilation and dysfunction. The severity of PR and its deleterious long-term effects are augmented by coexisting distal pulmonary artery stenosis or pulmonary arterial hypertension. Residual RVOT obstruction can occur at the infundibulum, at the level of the pulmonary valve and main pulmonary trunk, and into the branches of the left and right pulmonary artery. Elevated RV pressure and right ventricular hypertrophy have been described as independent risk factors for poor outcome and decreased exercise performance despite smaller RV volumes. Residual VSD can be due to partial patch dehiscence or failure of complete closure at the time of surgery. It may lead to LV volume overload. Aortic complications may occur many years after the initial surgical repair and include progressive aortic dilation and aortic regurgitation, rarely aortic dissection. The underlying mechanism is incompletely understood and may include ascending aorta dilation, abnormal aortic elasticity, or type of surgical repair, RV and LV dysfunction, heart failure. RV dilation is usually due to residual long-standing free pulmonary regurgitation plus minus RVOT obstruction. Significant TR may occur as a consequence of RV dilation, which begets more RV dilation. LV dilatation may result from long-standing palliative arterial shunts, residual VSDs, and or aortic regurgitation. Both RV and LV dysfunction may be due to long-standing cyanosis before repair and or inadequate myocardial protection during repair. Adverse ventricular interactions, electromechanical dysynchrony, and coronary artery abnormalities. A reduced LV free wall longitudinal strain has been reported despite preserved LV ejection fraction. The incidence of clinical heart failure with its typical signs and symptoms increases significantly with age. Underlying mechanisms may also be damage to myocardium, sequelae from surgical repair strategies, or electrical conduction abnormalities. Management strategies effective in acquired heart disease are frequently applied in these patients, although its effectiveness for RV failure remains uncertain. Atrial or ventricular arrhythmias and sudden cardiac death. Arrhythmias and sudden cardiac death are important late complications. The estimated lifetime prevalence of atrial arrhythmias is 20%. IART involving the cavo-tricuspid SMAS and right atrial incision are related to right atrial enlargement, whereas atrial fibrillation is facilitated by LA dilatation. Ventricular arrhythmias encompass polymorphic VT or VF, typically related to severely impaired RV and LV function, and monomorphic sustained VT, which are particularly relevant in repaired TOF. Although both polymorphic VT-VF and monomorphic VT can lead to sudden cardiac death, with a reported frequency of 1 to 3.5% in retrospective studies. The different underlying ventricular arrhythmia substrates need to be recognized for risk stratification and treatment. LV systolic or diastolic dysfunction and ventricular and atrial tachyarrhythmias are predictive of death and sustained VT in adults with repaired TOF. Possible risk factors associated with any ventricular arrhythmia and sudden cardiac death in repaired TOF are QRS duration more than or equal to 180 milliseconds, LV systolic or diastolic dysfunction, and inducible VT at EP testing. Older age at PVR-EP and pre-PVR-EP RVAs and dysfunction may be predictive of shorter time to post-operative death and sustained ventricular arrhythmias. The dominant substrates for monomorphic VT are anatomically defined isthmuses bordered by unexcitable tissue. Isthmus dimension and conduction properties can be evaluated by catheter mapping and likely determine susceptibility to arrhythmias. Targeting the anatomical isthmuses by catheter ablation has been highly effective to control VT. Whether catheter mapping can contribute to individualized risk stratification requires further investigation. Endocarditis can be encountered after both surgical and percutaneous PVR-AP. Valve-containing prosthetics are an important independent risk factor for infective endocarditis in the short and long term after implantation, whereas non-valve-containing prosthetics are a risk factor only during the first 6 months after implantation. A schematic overview of long-term complications after repair of TOF is provided in Figure 8. Now, diagnostic workup of repaired patients. Clinical findings mostly include a wide split in the second heart sound. A low-pitched early and diastolic murmur suggests severe PR. A long, loud ejection systolic murmur indicates RVOT obstruction. A high-pitched diastolic murmur indicates aortic regurgitation, and a pensystolic murmur indicates a residual VSD. ECG often shows complete right bundle branch block dependent on the surgical approach. The QRS width may also be influenced by the degree of RV dilation. Echocardiography provides assessment of residual RV OT obstruction and pulmonary regurgitation, residual VSD, RV and LV size and function. TR, RV pressure, aortic root size and aortic regurgitation. Strain measurements are helpful in quantifying the degree of electromechanical dyssynchrony. CMR is the method of choice for assessment of RV volume and function. pulmonary regurgitation, size, shape, and expansion of the pulmonary arteries, infundibulum, the ascending aorta, the position of great vessels or conduits in relation to the sternum, re-sternotomy, and evaluation for residual shunt QP/QS ratio. Late gadolinium enhancement demonstrates fibrosis, the extent of which relates to other risk factors for VT and sudden cardiac death. T1 mapping may have an emerging role. Cardiac CT provides information on coronary arteries, particularly important for the assessment of the spatial relationship with the RVOT prior to TPVI or surgery. The extent of conduit calcification, percutaneous valve anchoring, and the presence of major aortic pulmonary collaterals, that is MAPCAS. Cardiac CT may also be considered as an alternative for RV quantification in patients unable to undergo CMR. CPAT assists timing of reintervention and provides prognostic information. Holter monitoring, event recorder, and EP evaluation are required for selected patients, high risk, suspected or clinical arrhythmia, and or before RVOT reoperation. Inducible sustained VT carries prognostic value for clinical VT and sudden cardiac death. Cardiac catheterization should be restricted to patients undergoing catheter-based interventions, that is relief of distal pulmonary artery stenosis, transcatheter valve implantation, and when non-invasive evaluation is inconclusive. Before surgery, coronary angiography may visualize the coronary arteries, which is important to assess the spatial relationship with the RVOT prior to TPVI. Now this figure shows, panel A figure shows schematic of tetralogy of Fallot before repair. There is VSD, RV hypertrophy, overriding of aorta, and RV outflow tract obstruction. In panel B, schematic of repair tetralogy of Fallot with long-term complications indicated, that is atrial or ventricular arrhythmias and sudden cardiac death, peripheral pulmonary stenosis, aortic dilatation, aortic regurgitation, residual VSD, LV dysfunction, RV dysfunction, tricuspid regurgitation, pulmonary regurgitation, or RV outflow tract obstruction. This figure shows management of repair tetralogy of Fallot, long-term complications to address during follow-up. Now, late surgical or catheter intervention treatment. Late surgical or catheter intervention treatment. PVR, EP, and or relief of RVOT obstruction can be performed with a low mortality risk in patients without heart failure and or advanced ventricular dysfunction. PR is the most frequent reason for consideration of surgery. Optimal timing remains challenging. Longitudinal data are more important than single measurements to assist timing for reintervention. Normalization of RV size after reintervention becomes unlikely as soon as the end systolic index exceeds 80 milliliter per meter square and the end diastolic volume index exceeds 160 milliliter per meter square. But this cutoff for reintervention may not correlate with clinical benefit. A recent meta-analysis demonstrated that PVR-EP can improve symptoms and reduce RV volume, but a survival benefit still needs to be shown. Distal pulmonary artery stenosis must be addressed either at the time of surgery, including intraoperative stenting, or with a percutaneous approach. A biological pulmonary valve, genograft or homograft, seems to have a mean lifespan of 10 to 20 years, and future replacement could be performed by transcatheter valve-in-valve procedures. There is little experience with mechanical valves in this setting, and there is concern about adequate anticoagulation. Indications for tricuspid valve annuloplasty, closure of residual VSDs, and/or aortic root dilation or AR surgery should also be addressed at the time of surgery. The indication for aortic root surgery does not differ from the general population. TPVI techniques have become an alternative to open heart surgery, primarily in patients with RVOT, conduit stenosis or regurgitation, but also in selected patients with native RVOT regurgitation or stenosis. TPVI, when technically feasible, provides outcomes comparable to surgical PVR-EP and is intended to extend the lifetime of a conduit, hence reducing the number of reoperations during a patient's lifetime. Stent fracture, the initially most common complication, has become less of a problem with careful preparation of the landing zone using additional stents. Best long-term results were reported when a residual gradient of less than 15 mm mercury could be achieved. Uncommon complications occurring in less than 2% of patients include conduit rupture and coronary artery compression. The risk of endocarditis after TPVI remains a concern with an annual incidence rate of 2 to 3%. Since coronary artery compression may be life-threatening, a balloon test to exclude potential coronary artery compression must be performed prior to TPVI. Although this test carries a risk for conduit rupture in case of severe circumscribed conduit calcification, TPVI should only be performed if a cardiac CT scan shows sufficient distance between the conduit and the coronary arteries. The strong link between slowly conducting anatomical isthmuses and sustained monomorphic BT and the potential loss of accessibility to the anatomical isthmus by catheter ablation after surgical PVR-EP or after transcutaneous insertion of valves in patch-augmented RVOTs has important implications for patients who undergo re-interventions. Whether pre-interventional mapping and preventive ablation of slowly conducting anatomical isthmuses before or during intervention in patients without documented spontaneous sustained VT is beneficial is under investigations. Now, recommendations for intervention after repair of tetralogy of Fallot. So, recommendations for intervention after repair of tetralogy of Fallot. PVR-EP is recommended in symptomatic patients with severe pulmonary regurgitation and or at least moderate RVOT obstruction. Class 1 indication, that is pulmonary valve repair is recommended in symptomatic patients. Pulmonary valve repair is recommended in symptomatic patients with severe pulmonary regurgitation and or at least moderate RVOT obstruction is class 1 recommendation. In patients with no native outflow tract, in patients with no native outflow tract, catheter intervention TPVI should be preferred if anatomically feasible. Class 1 recommendation. Pulmonary valve repair should be considered in asymptomatic patients with severe pulmonary regurgitation and or RVOT obstruction when one of the following criteria is present, that are decrease in objective exercise capacity, progressive RV dilation to RV and systolic volume index more than or equal to 80 milliliter per meter square and or RV and diastolic volume index more than or equal to 160 ml per meter square and or progression of TR to at least moderate. Progressive RV systolic dysfunction, RVOT obstruction with RV systolic pressure more than 80 mm mercury. VSD closure should be considered in patients with residual VSD and significant LV volume overload, or if the patient is undergoing pulmonary valve surgery. In patients with sustained VT who are undergoing surgical pulmonary valve repair or transcutaneous valve insertion, preoperative catheter mapping and transaction of VT-related anatomical isthmuses before or during the intervention should be considered class 2A recommendation. Electrophysiologic evaluation, including programmed electrical stimulation, should be considered for risk stratification for sudden cardiac death in patients with additional risk factors, that is LV or RV dysfunction, non-sustained symptomatic VT, QRS duration more than or equal to 180 milliseconds, extensive RV scarring on CMR, that is class 2A recommendation. ICD implantation should be considered in selected tough patients with multiple risk factors for sudden cardiac death, including LV dysfunction, non-sustained symptomatic VT, QRS duration more than 180 milliseconds, extensive RV scarring on CMR, or inducible VT at programmed electrical stimulation, class 2A recommendation. Catheter ablation or concomitant surgical ablation for symptomatic monomorphic sustained VT may be considered in those with a preserved biventricular function as an alternative to ICD therapy, provided that the procedure is performed in highly experienced centers and that established ablation endpoints have been reached. Example, non-inducibility conduction block across ablation lines, class 2B recommendation. PVREP means pulmonary valve replacement. PV repair not, it is not pulmonary valve replacement. Pulmonary valve replacement. TPVI means transcatheter pulmonary valve implantation. TPVI, transcatheter pulmonary valve implantation. Transcatheter pulmonary valve implantation. PVREP means pulmonary valve replacement. Indications for electrophysiological testing and implantable cardioverter defibrillator. So, what is the indications for electrophysiological testing and ICD? An ICD should be implanted for secondary prevention of sudden cardiac death patients with cardiac arrest or sustained VT. What is sudden cardiac death? So, an ICD should be implanted for secondary prevention of sudden cardiac death, that is patients with cardiac arrest or sustained VT. ICD implantation for primary prevention remains controversial and no ideal risk stratification scheme has so far been developed. Patients with unexplained syncope and impaired ventricular function or other risk factors for sudden cardiac death should undergo hemodynamic and EP evaluation. In the absence of a reversible cause, ICD implantation should be considered. Now, follow-up recommendations. All patients with TOF should have periodic cardiac follow-up in a specialized adult congenital heart disease center, which in most patients should be done annually. Follow-up evaluation needs to look for the complications listed in section 4.10.2. All patients should have CMR at regular intervals, dependent on the pathology found. Now, additional considerations. Exercise and sports. There are no restrictions in asymptomatic repaired patients with good hemodynamics. Patients at high risk for clinical arrhythmias or sudden cardiac death, patients with advanced biventricular dysfunction, and patients with marked ascending aortopathy should be limited to low intensity activity or sports and avoid isometric exercise. Pregnancy. In unrepaired patients constitutes a considerable risk of maternal and fetal complications and death. The risk of pregnancy in repaired patients depends on their hemodynamic status. Low in patients with good hemodynamics. In patients with significant residual lesions, there is a risk of arrhythmia and right heart failure. Pregnancy is unlikely to have an adverse long-term effect on cardiovascular function. Infective endocarditis prophylaxis recommended only for high-risk patients. Thank you.